Good evening, everyone, and welcome to our Culturally Responsive Mental Health Care webinar. My name is Dane Purcell, and I'm a Mental Health Project Officer with Central and Eastern Sydney PHN. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. Just a quick note on housekeeping. This webinar will be recorded and it will be available on our CESPN our YouTube channel within the next couple of days. At the end of the webinar, there will be a survey that will pop up, and we appreciate any of your feedback, so please complete this to allow us to issue any certificates of attendance. You do have access to the chat function, which can be found at the bottom of the screen. So if you click the chat function, it'll pop up. So you'll be able to enter your questions and any comments that you have throughout the session. Just going to run through some programming and CPD programs for you. And while they're running through, I'd just like to introduce our speaker for the night, Emalynne So. She will be presenting on culturally responsive mental health care. Emalynne is a mental health consultant at the Transcultural Mental Health Centre, and she works specifically in the refugee mental health program. Her focus is on clinical services and capacity building with refugee populations. She is a clinical psychologist and has worked with migrants and refugees across the fields of chronic pain, medical rehabilitation, and psychological medicine in public and private settings. So without further ado, thank you, Emalynne. I'll hand it over to you and we can get going.
Great. Thanks, Dane. Hi, everyone. I'm just going to share my screen. And hopefully you can see that without, I'm hoping that's all
great.
Okay. Yep, awesome. Thank you. So as Dane said, I work as part of the refugee mental health program at Transcultural Mental Health Centre, and I've worked in all those different places that Dane had mentioned. And I just repeating that again, just because that kind of work influences, I guess, the examples that I'll give and some of the terminology I use. So if you've worked in sort of different places as well, you'd realize that, sometimes we'll refer to individuals as clients, patients, or even consumers in the mental health space. And I guess I try to use individual as much as possible, or the person's name. Some other sort of, I guess, a little bit more in terms of housekeeping. We've got about an hour and a half with a scenario at the end. So hopefully we've got enough time for some questions, about 10 or 15 minutes. It is quite content heavy. And I know it's a little bit tricky to be interactive when it's in sort of this webinar space, but feel free to add any sort of thoughts or questions in the chat box, and we'll get to them as we can. And if it's something that we need to immediately discuss, we can do that, or we'll look at that in the at the end of the Q&A section. The other thing about the content is just a bit of advice that there will be discussions around some difficult issues such as trauma and self-harm. So just want to, I guess, put that out there in terms of your own self-care. And if you need to take a break, please take that reflective moment. And if you need to, I've got my details at the end. You're more than welcome to get in touch as well. I live and work on Darug land, and tonight I am on Darug land. I want to acknowledge the Darug people as the traditional owners and ongoing custodians of the land, and pay my respects to their elders, both past and present. And I extend that respect to any First Nations people who are here with us today. And as we are online, I want to acknowledge the other traditional owners and ongoing and the custodians of the land that you're joining from as well. And so from the world's oldest continuous culture of our first Australians to the cultures of our newest arrivals from around the world, TMHC embraces and celebrates diversity. So I also acknowledge those with lived experiences as migrants or as refugees, and those with the lived experience of mental health issues and the courageous journeys of many generations of Australians who have made Australia what it is today. And before we begin, I thought I'd mention that it's Mental Health Month, which is celebrated each year in the month of October here in New South Wales. And the theme for 2024 is Let's Talk About It. And it emphasizes this significance of open dialogue and communication regarding mental health, and might encompass conversations of lived experience, navigating mental health systems, or seeking resources and support. And it's a really important theme when we're talking about our culturally and linguistically diverse communities, because sometimes that can be really hard, and it's a good I guess, start to talk about it as a first point. And so we'll talk about some of the resources and things that you can get. Way Ahead is website has a lot of information. So even if you just do a bit of a search on the website for Mental Health Month, you can download some translated resources related to Mental Health Month, or you can go to even the Transcultural Mental Health Centre website, and I'll talk a bit more about our resources in a moment. So what I guess we're going to cover today, it's really an introduction to building your skills, knowledge, and confidence in engaging with core communities, including people with migrant and refugee experiences. So really providing that culturally responsive mental health care. What I'm going to start with is really about building that context. So describing the cultural diversity in Sydney and the experiences of core communities, looking at some definitions so that we're all on the same page, looking at demographics and some prevalence data, and then looking at how we might explain that relationship between culture, mental health, and mental illness, looking at things like shame, stigma, how we might express our emotions differently based on culture, migration, and the historical context as well. Then we'll go through some tools and resources and services to support you in supporting our core communities. We're looking at that, I guess, in terms of two parts, looking at what we can do and how we can be. So providing that culturally responsive mental health care, and then looking at resources we can use relating to sort of cultural focused assessment tools, translated tools, and other TMHC resources. So as I go through these I guess, these kind of learning objectives, I want you to, and go through the material, I just want you to think of a patient or a client that you've seen. So that can help, I guess, center your thoughts as well as help generate questions at the end too. If you don't have a patient, then this is a person to think of, Aruna. So I'm just going to describe Aruna's story. Aruna is a 56-year-old female, originally from Sri Lanka. She presents to you with excessive worry about her life situation. She can't sleep anymore, and she's only getting about 3 hours sleep each night. She's known to you, but this is the first time she has disclosed a great deal of personal information. She has no family here in Australia and has just one friend that she speaks to on the phone who lives far away from her. When asked about her family history of mental illness, Aruna says that her mother had anxiety and took medicinal herbs to relax. Aruna reads in her language and watches Sri Lankan movies and goes regularly to the local RSL club to play bingo. She does not drink alcohol due to religious beliefs. With regards to her medical history, she has type 2 diabetes and arthritis in the knees and a bad back from her cleaning work over the years. When asked about mood, she says that she feels down and worried and cannot relax or concentrate and is fearful about the future. She has not thought about suicide, but she is very worried about her situation. So you can kind of keep her in mind. One thing I might mention as well is that I know that I think the audience I've geared this to is to GPs, but I understand there are some allied health people in the audience. So if there's anything that kind of doesn't make sense, or you want it to be a bit more tweaked to that sort of frame of reference, please just put a note in the chat box or something, and I'll see if I can tweak it a little bit or expand on that from a allied health perspective. Being a psychologist myself, hopefully I can do that through the material anyway. Okay, so just wanting to highlight some and making sure that we're all on the same page in terms of our definitions, because culture has multiple meanings and definitions, but the anthropological concept relating to how people live might be the most useful. So when we think about culture, it's something that develops on a social level. It's a society level phenomenon rather than an individual level one like personality. So it kind of grows and is nurtured, from human to human. We kind of learn these behaviors socially. And so we pass on what we've learned. So it's this evolving human culture. So when we think of culture, it's values, norms, beliefs, attitudes, and more, forming patterns that distinguish one group of people from another, be it a country, a region, an ethnicity, or some other group. So when you see that definition, it's understanding that culture is more than just race and ethnicity, but it's also other aspects. We can think of a person's sort of, I guess, even cultural identity as being part of, in terms of their gender, their age, socioeconomic status, a particular occupational group, allied health, GP, nurse, workplace, or even where we live, from eastern suburbs, western suburbs. And all those different aspects can influence the person in front of us as well as their difficulties. So culture can teach us how to think, feel, act, and how to interact with others, as well as how we might interpret the behaviors of others. We can consider this kind of in the way in terms of our work and how someone might engage with us with their eye contact, or even in terms of their, other things in terms of their body language. I know that I had a client once who would shake their head from left to right, so looking like a no in terms of the way that I've been brought up in terms of Western culture. And I was explaining some psychoeducation material, and it was actually his way of showing. I thought he was not understanding what I was talking about, but that was just the way that he shows his agreement and understanding, was shaking his head left to right rather than nodding his head up and down as we would think, or I would think anyway. So it's really thinking about how, culture shapes our social interaction and language facilitates that social interaction. So putting that together, everyone has culture. And when we're talking about culturally and linguistically diverse people, or that term culturally and linguistically diverse, it seems to limit that. And we'll explore that definition in a moment. But what I wanted to, point out is thinking about, what about us? And I want to give you maybe 60 seconds to think about, what aspects of culture are important parts of your identity. Because when we're doing this work, there is some implications of culture, not just with the person in front of us, but also for us. So I'll just I'll give you 60 seconds and just to have a think about that. So hopefully, I don't think that was quite 60 seconds, but it can feel quite long when you're doing it online. I guess I wanted to see if anyone had any particular, thoughts or reflections about this sort of exercise, about thinking about your own cultural identity. You don't need to go through specifics, but I was just wondering if anyone was willing to share what that process was like for them in the comments or in the chat box. Sorry. And I know it can take a little while to write. So as people hopefully will share their experience, I think in this space, it's really important to start to be culturally aware, considering how important parts, be it our beliefs, our values, our attitudes, might impact how we might engage with others and influence our clinical work. So it doesn't look like anyone's brave enough, or people are a lot slower at talking than I am, typing than I am talking. The other thing, I guess, if we think back to Aruna, just thinking about whether or not we are providing, an assessment or a session or a treatment, or engaging with her, whether it's culturally congruent, like we're from the same sort of background or similar background, or are we going to be doing this cross-culturally, and what does that look like? I can see, I'm sorry if I mispronounced your name, Soraya's written a sense of belonging to a group. Great. Yeah. And I think that's one of the things about culture. It's this idea that we're part of a community, and that sense of belonging can be really important when we're thinking about how we might feel in terms of our mental health. I'll keep going, but feel free to add any more comments. So how might culture be thought about in the mental health care context? So firstly, the definition of transcultural. We're looking at this process of interaction between different cultures. And so it could be that sense of belonging that Surai's mentioned. It could be that sense of belonging to different groups as well. And it might feel differently with those different groups that you might make part of that transcultural sort of identity. What is great about this paradigm is that it does identify and acknowledge the interaction of cultures, and it enables that building of identity from race, ethnicity, gender, occupation, location, geographical location. It's that freedom to belong to many cultures, and building sort of that when we're engaging with other people, feeling that there's this equal partnership, equal attention and respect to cultures of both parties in that sort of engagement in a therapy room or in a GP sort of setting as well, a medical center. So when we compare that to, the term cross-cultural, cultures are, compared and contrasted, and transculture goes beyond comparing those characteristics between cultures, and it goes beyond barriers. Multicultural seems to restrict those, restricts individuals to one particular culture, and it doesn't seem to imply that actually there is diversity within and between communities, and particular ethnic communities or countries. And you can kind of think about this with refugees, where sometimes you can see that some refugees would be trying to escape persecution because of their particular ethnicity, and so there's these oppositional cultural identities within a country. Australia, which has a significant migration history, there's cultures merging and converging, and that migrants' journey of their culture is just dynamic and evolving. And so people undertake this transcultural experience that impacts them and their descendants. So these factors are influencing intergenerationally, their children, their grandchildren, and this paradigm helps acknowledge that intersection of identity and helps contextualize that person's expressed levels of distress, help seeking pathways and attitudes towards, services that are provided to them. And in our roles to help support, patients succeed, we must understand the lens through which they are perceiving their world. And this kind of hybridity of cultures can also cause conflict for the transcultural migrant who tries to navigate two or more cultures. You can think of like a teenager having to go through sort of the developmental stages and then having to navigate both what's happening, with their peers, as well as what might be expected of them at home. And it might be us trying to help them navigate and not having to see that they've got to choose one or the other, but that they can, find almost a happy medium to be able to manage both and still, have good mental health. So it's thinking about that frame of reference that person has, their transcultural lens, how might others identify themselves? How might others identify us? And how might we identify ourselves, thinking about what's our transcultural lens? What are we using? Are we using our language, our country of birth, sociocultural upbringing? And we need to kind of consider these, concepts in our work. So who are we talking about? So I guess to provide context around cold Australians and just using some census data from 2021, there was over 7 million migrants living in Australia. And if you're looking at people that have at least one parent born overseas, that's over 50%. And the top 5 countries of birth are China, England, India, New Zealand, and the Philippines. I won't read out the other stuff on there in terms of ancestry and language. What I will mention, though, is with growth communities, what that refers to is the top 5 countries of birth where there was a growth of greater than 20,000 people between the census in 2016 and 2021. So I guess what this kind of shows on the screen is just that diversity that we have in Australia. One thing I might note is when we're talking about culturally and linguistically diverse, there is that definition, as I said, there's limitations to it. And when we're looking at what's on the screen, it's only a few aspects. I've only got really country, I haven't got it on there, but it's about where you were born, whether you were born overseas or born here, your ancestry, as well as language. But we could also think about, religion, ethnicity, which isn't captured, English proficiency. And when we're thinking about a person, they might be born in England, but that doesn't necessarily mean that they're English. They might be of a different ethnicity. They might be of a different ancestry as well. They might have a Chinese ancestry and then speak different languages as well. So it's really thinking about this intersection of aspects and also considering what term a person might use to describe themselves. And COLD is a government term that's used, and only specific to Australia as well. And we've also got the term migrant, which I think I have on the screen. And then you can also think of that second generation migrant. And a colleague of mine uses person of color to describe themselves. So it's really coming back to, thinking about what term does that person use. So I've got the New South Wales census data up there. It's really a reflection of what's happening nationally. In terms of Central East Sydney, PHN, you can see that there's a higher number of people born overseas. And when you include people that have one or more parents born overseas, that goes up to 66.4%. And again, I guess it's looking at how diverse the communities are and how it's important, that there are these organizations like ourselves that work in this space, as well as you coming to training like this. So before looking at prevalence, I thought I would just put a reminder and a review of what we mean by mental health. So mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. So what that means is it's more than the absence of mental disorder or illness, and that mental health is an integral and essential part of health. Indeed, there's no health without mental health. And it's fundamental to our collective and our individual ability as humans to think, to show feeling, interact with others, and earn a living and enjoy life. So what might the stats say about the prevalence of mental illness and service use in Australia for core communities? Now, there was a report written almost 14 years ago about this, and not much has really changed. And what the report found was that there was considerable gaps in the data on the prevalence of mental health disorders, and it hasn't been actually adequately captured data on core communities. So there's no comprehensive Australian study on study of migrants and refugees as well. And a lot of it is the issues around how this data is captured, whether we capture this via language, country of birth. The group is very heterogeneous, and so it makes it very hard. You can see a lot of research, but it's on particular groups of people. However, I guess what the limited data does suggest is that, generally migrants, refugees, and asylum seekers, there are lower rates of mental health service use versus those that are Australian born, and that there is an overrepresentation in involuntary acute inpatient admissions. And that was recently actually, found in a study around New South Wales Health inpatient admission units, where there was more people in involuntary admissions of those from born overseas and also speaking another language, so that there was actually a difference in rates. And so that was just in a journal article that was published this year. So there's a lot of issues that can happen because of that as well. They might be more likely to be exposed to quality and safety risks. There might be misunderstandings and misdiagnosis due to language and cultural barriers. And diverse cultures in countries like here, the Canada and the US, people seek help much later than those from the general population and present in acute stages of mental distress. So why might that be the case? What we need to kind of consider is sort of three broad issues when providing care. It's at that accessibility. Are they able to understand what they're attending? Do we need to provide support around that? Translations, reminders of appointments in language. So it might be some more practical things like transport. The other thing is cultural adaptation of services. Can we do something that's best of both worlds, supporting a person within their cultural context whilst within our system of care? and also considering these broader social determinants of health. Things like discrimination, what their starting point is, looking at these social determinants of health is potentially, I guess, is beyond the scope of this introduction, but it's thinking about things like health equity and human rights. And I guess what we want to note here is that there are going to be variables outside of a person's control that can still impact a person's mental health. For example, you can think of a refugee child being born in a refugee camp and their ability to access basic needs, even compared, we can even think about that in our own society, thinking about people and how they might access services if they were born in an urban area versus a regional area. And so I guess before we look into that a bit more, what I wanted to take a look at is sort of the migration experience. So it's a lot of information to digest. So if there's any questions or comments, feel free to add it to the chat box and we'll get to it. So I guess the other part is to think about the migration experience. And we can think of the migrant and the refugee experience being considered in three parts: pre-migration, the journey itself, and post-migration. And each has its issues to consider in the context of mental health. This is not an exhaustive discussion, but I guess it's just highlighting some things to consider for someone. So when we think about that pre-migration space, we're thinking about these motivations, these push and pull factors relating to economics, political, that might push them to leave a country, or something that pulls them towards another country. May it be employment, reuniting with family, or things more related to freedoms like marginalization, persecution, or even natural disaster. And things can also happen on a macro level, so things that might impact on a society level, like war, at a meso level, where they might be persecuted because of their religion, or at a micro level, looking for things at an individual level, I guess in education or employment. The journey itself, when we're talking about this, it's thinking about that level of stress in terms of moving. There's obviously excitement about it, but there might also be trepidation. So, I guess a lot of it is also that there might be more issues for those who are seeking asylum, with potential ongoing trauma and human rights violations if they go into a transit country or in immigration detention. But I guess overall, if we're thinking about, and I will talk a little bit more about forced migration in a moment. When we're thinking about migrants generally, it triggers that stress response, and then it might, physical or psychological, and it creates a vulnerability to future stresses. Then looking at the post-migration experience, thinking about settlement as this time of adjustment, and it can be quite multifaceted and complex, where there's, different sources of stresses, might be socioeconomical, trying to find employment, housing, political or language barriers would impact all of that as well. Political, there can be, racism, what might be shown in the media, discrimination, and also in terms of the cultural context, there could be different rates of acculturation between parent and child, which can then cause some intergenerational conflict as well. And that can come down to things like learning the language at different rates. And then that sense of that power difference between the parent and the child that might shift from their heritage country to the host country, where the child might learn English at a faster rate than the parent, and then the parent has to rely on the child to understand what's going on. And so you can see that shift of power could potentially cause some conflict in a family. And yeah, so I just wanted to add a little bit more, I guess, about that forced migration journey, and just thinking about some of the things that someone might experience, because their migration experience would be very different for someone that's from a refugee or asylum seeker background, and largely because the reasons for leaving are forced, while migrants have that freedom to leave and can also return if they want to. So that has those clear impacts on mental health. And it's really, I guess, understanding that, each person's migration experience is going to be very individual, where some might have to leave some family members behind, and, taking that trauma-informed and holistic approach, and really noticing how lives are impacted regardless. So culture can influence how mental health is experienced, help-seeking behaviours and access to service, and that migration experience as the context for culture and mental health intersection. So it's that frame of reference that, thinking about the social context and the norms aren't necessarily Australian culture. So that, thinking of migration as a process and not a single event, as well as the fact that culture evolves. So, it's this, the acculturation and the migration experience. So we can consider that, the migration experience has this vulnerable population to develop mental health issues, because there can be challenges with migration and that can impact on that person's mental health and well-being. You know, I just wanted to add, I guess, when we're thinking about, parents who might migrate, they might think that this is, or, most, just trying to think about parents and children as an example, they might have this hope for a better future for their children. And this pathway can be very challenging for migrant parents because they've got to deal with the normative challenges of parenting, as well as, adapting to these new norms, values, and expectations. And that might be at different rates from their child. So, what are the cultural implications in mental health and illness? So I want to give this, I guess, a brief overview of the impact of culture on mental health. And you might be aware of some of these and what you might do if you see, and I just want to go through some of the things, what you might do if you see this in your, the person that you're seeing, your patient, your client. There might be shame and stigma. They're worried about the reputation, not just of themselves, but also their family. So they don't want to attend a mental health service. They might not want to open up, and they won't actively seek treatment despite their suffering, because they see themselves as, representing, not just themselves, but their family, community. So what we want to try and, I guess, do is kind of need to normalize what's happening, provide that education. We also might ask questions that are less intrusive. We might ask about physical symptoms or activities, like, how's your sleep going? What's your sleep pattern like? How's your appetite? Or is there been any change in your weight? How's your energy levels? What are you kind of doing on a day-to-day basis? And that might lead to more questions to help establish if there is a mental health diagnosis. Understanding of mental illness. There might be no definition in their language or culture. Their attribution of the cause might be something that's quite fatalistic. They might think it's in, I've heard of people going, it's in God's hands. There's nothing that I can do. There's no point in seeing a psychologist. Or, I don't want to take any medication. So it can really impact how they might take up counseling, how they might take medication. And so it might need, again, sort of time to educate and explain, or it might be providing written translated information. Things like we've got on our website, we've got translated information on antipsychotic medication that can be in particular languages. And that might help people understand that they're not the only ones that are having this happen to them, and they might have better understanding of what that medication does as well, just to support, the things that you're saying or trying to explain to them. And especially if they're in a distressed sort of, feeling quite emotional, they might not take in anything that you're trying to explain to them. And so it might be helpful to have those written information in their language. There might be also differences in how they might express their emotions. Some might only talk about physical symptoms or emotional symptoms or both. I know I've had clients, from all the way back, seeing Cambodian and Vietnamese clients who spoke of headaches and nausea and dizziness. And then to more recently having some Afghan refugees talk about headaches as well, and also low back pain. So, it's kind of a little bit less stigmatizing or shameful to have maybe physical symptoms than having those emotional symptoms. So they might downplay those mental health issues rather than talk openly about them. And, you can even think about the grief experience and how that can be different for different cultures as well. So what we might do, I guess, is to suggest things that might fit better with their cultural beliefs or it might be fit better with what symptoms they're presenting. You know, if they're not wanting to discuss or talk about it, then maybe recommending counseling, straight away isn't very helpful. It might be trying to provide information to read, or something more active, more physical, if they're providing some information more about how they're, having sort of low back pain or feeling some pain. And so giving them exercises or walking as well. You can think about Aruna and consider what her symptoms were. She was talking about some physical symptoms, and maybe it's about talking more about physical symptoms first, although she seems to be open to it because she did speak about her mum having anxiety. But I guess it's just really starting to help them, open up any discussions about any possible mental health related issues. And what else? There might be this lack of knowledge and understanding of services. So they might not even know what is available, understand what each service does. And that could just simply be because of the language barrier, or it could be just different priorities. They want to try and meet sort of basic needs first, wanting to work out where they're going to stay permanently, and then know where to, put their kids in for school, if we're talking about newly arrived Australians. And so it's really trying to help people understand, giving that time to explain or provide a brochure or a website about some of our services. It's really trying to, I guess, reduce any sort of misunderstandings that people might have about how how interventions are, what medication does, and just really trying to help understand the differences in health systems. And some mental health, I guess, services overseas can be quite scary. From some of the things that I've heard about other countries and how they look after people that are identified as having a mental illness. And so we've got to kind of try and break down those barriers and understanding of how our mental health service works, so they're more likely to seek help. So I guess if that kind of goes into this migration experience and thinking about how, if someone's gone through this forced migration experience, has a refugee or asylum seeker sort of experience, they might not want to access services as well if they've had adverse situations with authority figures. And it might be needing to sort of help them understand what our role is like as a GP, as what seeing a psychiatrist might look like, or what seeing a psychologist might look like. And especially if we might not think of ourselves in I guess, a place of authority, but they might see us that way. And so it's trying to make them feel comfortable, be more culturally responsive, and we'll talk a little bit more about that. But just really taking that trauma-informed approach, and how they might engage with services and authority, that it can impact them. And so if they've had these experiences of traumatic events, you might ask them more about how it's affecting them now, rather than the specifics of what happened, and normalize that people who are forced to leave have had terrible things happen to them. And it can be this complex interplay of pre-migration trauma, individual differences, and experiences in once they migrate, in the host country, I guess, or in Australia, that acculturation experience, that settlement period. And if you find that there is trauma and torture established, then maybe it's about referring on to a specialist service like STARTS. So I guess the other thing I might add is just around this power difference, just really taking, I guess, thinking about how that looks like. So it's really, using sort of this reflective practice about how that interpersonal power difference might impact someone. Because when we think about the historical context of some cultural groups, there might be this mistrust of clinicians. They might have had past experiences of racism and discrimination, and that might then impact when they will access services, especially if they feel that they've been discriminated against because they're, dressed in relation to their faith, and it can be clearly identified and it's impacted on them. And then the last bit's around practical and logistical barriers, things around transport, childcare, financial limitations, work commitments. So they might have different priorities. And I guess this is where it might be quite hard, but I guess it's trying to work out how can we work with their priorities, really thinking about what can we do to help support them in their priorities. And even when we can do that, it might actually help reduce some of their mental health issues. And it might be looking at trying to find other providers that they can engage with to assist them as well and giving them that advice and education. So, overall, these implications can impact on, the mental health service use. So, um, so what I want to go through is the idea around cultural safety and responsiveness. And so I got distracted by Soraya writing something in the a chat box. It looks like it's a book, maybe. But you can explain a little bit more and then we can talk about it at the end. So what is cultural safety and responsiveness? So, when we've got these cultural implications, how can we take this account? Where do we start when we're being culturally responsive in our mental health care? And we can, when we look at, I don't know, if you've been around long enough, I guess, in this space, you would have potentially done cultural competency training. And there's been, I guess, this evolution around the training in this space. We've gone from being culturally aware to culturally competent and culturally sensitive, and then looking at trying to be more culturally safe and responsive. And I guess one of the issues is that when we think or talk about being culturally competent, previously it was, I guess it's like a technical endpoint. We've done the training, it's a one-off training, and that's done, we're ready, and we can work with anyone. But it really doesn't, it kind of thinks about human behavior, talks about stereotype, it really stereotypes the human behavior. It doesn't recognize that there are differences within cultures and the very individual experiences people have with mental health issues when we're considering their transcultural lens. So we need to be more than just being competent. And then the idea of cultural safety emerged in the 90s, where Maori nurses found barriers in being clinically effective because of this inherent power imbalance. And so when we're talking about being culturally safe, it means we're attending to this power dynamics, the system discrimination. It might be difficulties by accessing services because of language barriers, and that's when health inequity can happen. And as health professionals, we need to be aware of this and consider this when we're engaging with the person and that interpersonal power difference between ourselves and the patient. So it includes this idea of reflective practice, which I've kind of alluded to already, and we need to consider how we can empower that person to then feel safe. And so it's more than just learning about cultural customs and being competent, but thinking about that difference and the power dynamics at play. So it's really looking at examining ourselves, the potential impact of our own culture on that person. So when we're talking about cultural responsiveness, that has cultural safety at its core. It's transformative by incorporating knowledge, so what we know, that awareness of our own self-knowledge and behavior, so through our actions. It is really this approach we take in engaging with people and how we act to embed what we learn in practice. So it's this genuine dialogue to improve practice and health outcomes. So it really goes hand in hand with trauma-informed care, thinking about empowerment, that choice and control, the autonomy, making people feel safe and building that trust and being collaborative. The other thing I just wanted to add was the idea of cultural humility, and it's this idea about having this willingness and ability to listen and learn from people about their lived experience. So it's this openness to understand that another's experience and awareness to our limitations in that understanding. So it's not a catch-all strategy where one size fits all. It's more than that. So when we're thinking about coming back to Aruna, how do we manage this power dynamics? How can we mitigate it, make it more equal? How can we make her feel safe, especially when we're aware of potential cultural issues? Okay, so how can we best support core communities? So just like, I guess to summarize the discussion so far, we need to consider that person's unique cultural needs, be aware of differences that can exist within cultures, and, and subcultures and identities can exist. That intersection of age, socioeconomic status, cognitive abilities, gender, it creates this unique experience under specific circumstances. When we think of Aruna, parents might be from rural or urban area, college educated or not, the mental health history in that family, being female, alone, no family, what are the expectations there and issues that might have arisen for Aruna over time in Australia. Thinking about what family and cultural values might arise and trying to assess this in context, kind of using a very systemic or ecological framework. Is there any interdependence that she has or might not have with her family? And does she have that interaction with the Sri Lankan community as well? Or what about her spiritual or, religious beliefs? Is that part of her upbringing or is it new? What impact does that have when you consider the assessment and referrals for treatment planning and potentially discharge planning, depending on the context? It's then looking at, her resilience, sort of the coping strategies as well. Maybe they can be enhanced through understanding her experience of migration, her strengths, her abilities, coping skills, whether we might be able to include spiritual, strategies, prayer, or any other sort of thing to complement health, I guess, our health system. And generally speaking, thinking about language and cultural barriers, how can we reduce these barriers so that we're not then having misunderstanding and misdiagnosis, trying to improve that clinical care and ensure that we're increasing levels of disclosure. Interpreters, help mitigate this quality and safety risk by ensuring that we understand, what is happening for this person. I know that it might not be an issue with Aruna, but it's something that we want to consider because communication is really important so that we can understand what's going on and even help people understand confidentiality, because that can be quite a huge issue in community. And so it's really about trying to make sure that we're explicit, we're addressing concerns, being clear about recording and breaking confidentiality, what circumstances we might do that. And it might be having to explain it in different ways, as it might not be readily appreciated because we want to ensure that they understand confidentiality. And it can get really tricky, especially when we're talking about smaller ethnocultural communities as well, when there's an interpreter present. And it's trying to negotiate how can we best support that person and make sure that they understand the trust and the confidentiality and how that relationship works. And so it brings us to that therapeutic relationship. Here we can start thinking about how we might show sensitivity, respect about the cultural practice so they can engage with us, feel trusted, feel empowered. It kind of goes back to some of the basics around, being empathic, that communication style, body language, trying not to be maybe prematurely intrusive as well with our questions, back to sort of that sort of basic things around building trust and rapport. And it's being flexible and patient, allowing them to explain in their own words at their own pace. It's, really, I guess, trying to minimize that non-disclosure. And I know that can take a lot longer and sometimes we might not have that time to do that. So it's kind of trying to work out how can we do this so that that person will do that. It's using our trauma-informed care principles as well so that they can build that confidence, trust through that informed choice and see that they've got some control over their situation, which they might have lost. So then it comes to that, back to reflective practice. What do we bring? What do we need to be aware of? It's really having that increased awareness of ourselves, acknowledge some of our limitations, but also our strengths, in our prior knowledge and training, thinking about, how, is there any sort of bias, any assumptions we might be making? How do we influence that person in front of us? And how is that person in front of us being influenced by us when we're having these conversations? Are we showing sort of our shared understanding? Are we ensuring that we're not making any assumptions? And are we, I guess really in sum, it's we need to remember the context, the communication style, working collaboratively and developing our cultural understanding. It's really remembering, hearing other stories is not the same for everyone. It's understanding the power of hearing more than one story. And the key is really around our communication to build that confidence between yourself and the individual. And so that if they need support again, that they will come back. So it's really about enhancing that continuity of care. So they'll come back for services if it's needed again. It might not be you, but it might be someone else in the service or another health professional if they've had that good, I guess, encounter or engagement with someone. So now we're going to sort of these culturally focused resources that might be able to help support you in your work. And so these resources can be used to sort of help you understand the cultural impacts of someone's mental health. So we've got I'll go through the 4 that's on the screen, and we'll share some links, about, of these as we talk about each one of them. And you can keep that person in mind, one of your clients or patients, or Aruna in mind as we go through them. So the first one, Kleiman's explanatory model of illness, is a good starting point. It thinks about culture as a context, and you can collaborate with an individual on the formulation of their concerns. So it can provide, questions that try to gain insight into that person's worldview, their culture, social context, and spirituality. Really trying to work out what's most important for the client in terms of their health, illness, and care. So you might, use something like, what have you been doing? Question 8 is, what have you been doing so far for your so with Aruna, looking at her sleep, she can't sleep, so what have you been doing for your sleep? And that might give you some insight into her beliefs. And I guess this is sort of a given, but a reminder, making sure that we gently ask, plenty of time to consider replies, and it might be quite informal the way that you might do that. And it's really just coming to this point of having a mutually interpretable explanation of what's going on. The next one is the Transcultural Assessment Checklist. This is something that was developed through Transcultural Mental Health Centre, and it's a bit of a mental checklist for a cultural assessment, and you can use it at any time on the clinical pathway. And Dane kindly shared the link in the chat box. And so it goes through a lot of the things we've been speaking about, so you can look at it before you might meet someone or you might have it with you. I think, sort of, I guess, prompts around thinking about your own cultural background, theirs, any expectations they might have. And then on the flip side of this checklist, it's got the areas that you might ask questions around person's cultural identity, migration history, what their perceptions of illness are, and thinking about helping you to create that understanding of what's happening culturally and whether that is actually impacting on a person's presentation. If you've got a real interest, just talking, I guess, to the GPs around mental health, then you can delve a little bit more by using the DSM-5 cultural formulation interview. So this sits at the back of the DSM as an emerging, in the emerging measures and models part, which is the culture and psychiatric diagnoses. You can download this from our website as well. And it's basically a set of protocols and 16 questions that you can use during an assessment to help integrate the impact of cultural and social context in a clinical diagnosis. So it's really an expansion of those questions from Kleiman's, looking at a person's cultural experience of illness, help-seeking behaviors, and it just adds to that formulation of a person. They also have an informant version as well if you were wanting to integrate that in part of your assessment of someone. So this is the some translated, you might use translated mental health screening tools if that's something that you might use usually in your practice. it's so we've got a whole bunch of these on our website, as well as I guess translated tools for seniors and for younger people. So you can just have a look at RUDAS, K10, GAD7, PHQ9. And it's also, I guess, a good starting point, especially to talk or can't articulate their symptoms, but just considering also that person's literacy in their own language and whether it's necessary or appropriate to use it. They might, you don't want to be overdiagnosing or medicalizing someone's suffering, especially if they've had, history of multiple traumatic events, and that can be just being mindful of how that might impact I guess how you would interpret any of these questionnaires. The other thing I guess also to think about is, I've had a client who said they could speak English with me fine. They said they could read English as well, and they were from a different background. I can't quite remember anymore what language or what ethnic background they were. But they read the depression, anxiety, stress scale where I was working, and the question was around being downhearted and blue. And they could read it obviously, but they didn't quite understand what that meant. And obviously, once I start interpreting that for them or trying to explain it to them, what downhearted blue meant, or they found it hard to unwind, then those kind of things then would impact the reliability or the validity of that questionnaire. So it's just being really mindful of how you would use these. But like I said, you could use it maybe to help start conversations as well. Now, as you might know, is that, health literacy in some cold communities can be, poorer in some than others. And so we want to try and build that because it does impact their engagement with treatment. And we can use strategies like the teach back strategy and the learn model to help improve communication and build coping strategies around mental health. And hopefully, I guess, as health professionals, it's second nature for us when we're discussing treatment plans and asking them to repeat care instructions back to validate their understanding. And then we can, I guess, correct misunderstandings this way. And so what I've got on the screen is that teach back strategy, just a reminder, I guess, of, making sure we use plain language, rephrase our message if we need to as well, focus on 2 or 4 points and start with the most important message. And we might even use patient material, pictures and or diagrams. So it might even be translated material. And, you could use I'll just use as an example, you might use this for confidentiality. I want to make sure that I've explained things clearly. Can you explain to me what the limits of confidentiality are? The other one is the learn model. And, these might be putting, I guess, labels on things that you already do. So the learn model helps eliminate, communication and cultural barriers between ourselves and the person in front of us to improve that engagement. So it's about listening to that patient's perception of the problem, and then for us to explain our perception of the problem, and then both parties trying to acknowledge and discuss those similarities and differences between perceptions, and then thinking about what are the recommendations for maybe the treatment or what we might do next, and then negotiating, between the health professional and the individual, trying to work out how best to go forward with whatever is being discussed, like a treatment plan. And you might be able to see these as things that you might be able to adapt for your own use to help reduce miscommunication. And what else? So there are technology tools. There's the Cold Assist tool. It's not to replace interpreters, but it might be helpful. It's a free communication app just to support, basic patient care. It's been endorsed by the Ministry of Health, but just checking that it is fit for purpose, because there are, more low risk and basic care stuff. It might be somewhere in reception where you might be like, do you need glasses? Have you seen a dietitian before? I need to take some blood for a test. So really basic stuff. So just really checking that it's fit for purpose. And then there's the appointment reminder translation tool. So both of these you can download and are available on the Multicultural Health Communication Service website. So not sorry, that's the Cold Assist app, but the appointment reminder translation tool is a website, and you can just go in there, put all your details in, and things around the appointment details, the person's details, like the number or email address, and then you can send a reminder to that person. So you can do it as an SMS, an email to the person, or you can print a PDF and send it via post if that's the preferred method. And you can add your service details as well. And it's a really simple, basic way to provide that reminder in language, which I found really fantastic when I was working recently with some refugee clients, and that was a really easy way to do it via email or SMS in their language. So you can look at that off the Multicultural Health Communication Service website if you haven't heard of it before. And then there's some translated resources to help, that education and improve that health literacy. And it does help them think about, it kind of helps with normalizing that it's not just me, and it is quite common. So on the Embrace Multicultural Mental Health site and the TMHC one, we've got a lot of translations around mental health. The Multicultural Health Communication Service has multilingual health information on things other than mental health. So all those websites are very helpful to help support you in your work. And if we think much more, I guess, holistically in our approach, it's also thinking about community and CALD specific organizations. It might be about engaging with specific, community specific leaders, ethno-specific organizations, spiritual leaders, and that might help sort of get a good idea of what's going on for someone, how we can support them. We actually have on our website, and I think Dane's actually shared our website in the chat box as well. We have community mental health profile lists, and on those lists it has some resources like organizations that are specific to particular communities. If you're finding it difficult to find that information, you can go on our website about that. So it's really thinking about that person within an ecological framework. And there's also, that's not exhaustive in terms of those resources, but those are just highlighting some of them. And I guess if there's any sort of issues that are specific like trauma, then it would be, like a place like Starts that you would, refer someone to. So I guess, Transcultural Mental Health Centre is more than just translated resources. This model shows just how we work in terms of that multi-pronged public health approach and how we might support CALD communities and service providers, and we do it in many ways. So this is currently our services and programs and how it looks like, but it is ever evolving to meet the changing needs of CALD communities. And each arm works in conjunction with each other to provide that effective delivery of mental health care for culturally diverse groups. And this requires multiple interrelated components. So I'm just going to do a really brief review on how on each arm and how it can support you in your work. So the first one I wanted to go through is that specialist clinical services. So the red circle. And we have two services. We've got the Transcultural Mental Health line, which is on our next slide, and our newest service, and I'll explain that in a second. And then we also have our clinical assessment service, and it's internal to public mental health, and it's a secondary referral service. So it supplements your New South Wales public mental health, and we have bicultural and bilingual consultants that facilitate that better communication and understanding. So for those of you that are outside of New South Wales Health, you can still contact this service for cultural consultations. And what that means is that if you needed help to understand cultural issues, say, for instance, we're talking about Aruna here, and she was from Sri Lanka. Oh no, India, I think. No, it was Sri Lanka. Sorry. It might be about contacting us to get some extra information about her culture that might not be on our website. And that would give you a little bit of a piece of a puzzle around Aruna and her history. The other one that I guess the other few I wanted to highlight is the mental health, so the blue one, the mental health promotion, prevention, early intervention. And this is the community promotion arm, and it partners with other services for in-language mental health literacy sessions. So looking at reducing stigma at the community level. It also has these open carer support groups that provide sort of support, information, social activities, all in language. So for example, there's a group in Granville that speak Dari and Farsi. In actually, I think that there is a Korean one, but I think it's moved, but it was in Rhodes. There's Vietnamese ones in Bonnyrigg and Cabramatta, and an Arabic speaking one in Harris Park. We have a whole bunch of them, and if you had a carer that was interested in attending, just let us know or get in touch, and we can try and link you up to the leaders of each of those groups. In terms of the education, training, and clinical supervision, we have other training and webinars that sort of like a deep dive or something a bit more specific around maybe older people that are from CALD communities, or young people, families, or a little bit more on cultural assessment and cultural formulation. So we've got a lot of different types of training available. Just need to get in touch. And then we also have a lot of publications and resources that you can download for free from our website, or you can order it as well for free. And I think I'll be able to show you a little bit more about that in another slide. And then the last one, or not, I mean, the last couple, although they're just as important, is our research support and academic partnerships and our service development planning and evaluation. And so we do a lot of consultation and advice on the local, state, and national level. And we also partner with academia to build and identify those research gaps that can happen with our core communities. So as I mentioned, we have the Transcultural Mental Health Line. We have over 30 languages available that are a direct service to clients and consumers who are not linked in with mental health services and can provide mental health information or mental health service access. There's also short intervention that can be provided by our clinicians. It is not a crisis service as well, but it can support families and carers too. So you've got the number on the screen. It might be that we'd have Aruna, she might call here, or it might be trying to find out if you're already providing her support about services that might be supplemental to what you're doing. It might be an ethno or ethno-specific or religious-specific organization, and you can find out that information from TMHL. And it's a completely free service as well, and Medicare isn't required to access it. So as I mentioned, we have some translated resources, and these can be downloaded from our website, or you can order them for free. And we've had some updates in terms of languages recently, some new and emerging languages, including Nepali, Pashto, Burmese, and Ukrainian. And it's all about, as I said earlier, is building that mental health literacy, supporting any psychoeducation, and normalizing that experience. And we have them in sort of, I guess, subjects that are non-stigmatizing and palatable. So things like sleep, stress information. As I mentioned, we also have, I guess, handouts that support discussion around medication, like translated information on like things like antipsychotic medication. And I also mentioned what we have on our website is these community mental health profiles to help you inform the picture of individual stories as well. And so we've developed some in relation to crises like Syria, Afghanistan, Ukraine. We also have ones on particular populations like older people, young people. And we also launched one last year during Sydney World Pride, noting that layers of discrimination, prejudice, and stigma can happen for those in the LGBT community. And so we did one specifically, excuse me, for people from that are LGBT people from CALD backgrounds as well. So you got the email up on the website, so you can email us to request any information that you wanted in hard copy. And I guess coming back to Aruna, you can build up her mental health literacy by providing some information around sleep, or it might be, reading up on her cultural background. As mentioned, TMHC is ever evolving. So this wasn't featured in the original diagram, but this relates to, I guess, the the education and training arm, as well as the mental health promotion, prevention, and early intervention arm as well. And this is the program that I sit in, so I thought I should mention it. It is a statewide program, and it focuses on better outcomes for the mental health of refugee communities. So we've got two components that work in tandem. So we've got someone that works, I guess, in community engagement to prevent that mental health issues, promoting good mental health and reducing that stigma. So hoping that to increase their access to mental health services when they need it. And then we've got the clinical component where I sit, and it's about building those skills, knowledge, and confidence of, supporting and strengthening the skills of health professionals in services to provide that, culturally responsive mental health service to newly arrived refugees. So I know we're not talking about Aruna. I don't think we've said that she's a refugee, but we can see that they could benefit indirectly from this program, where we've got our mainstream sort of clinicians improving their skills, and then within the community building that mental health literacy. Um, so here's Aruna's story again. And we've, I guess we've come to you've decided that Aruna's experienced symptoms of anxiety and would benefit from psychological intervention. You begin the process of doing a mental health care treatment plan, as you do not have time to finish the plan in one consultation. So this is kind of, I guess, in a context of a GP consultation. You only have 10 minutes in the consultation, as there are a number of patients in the waiting room wanting to see you. So I guess the question is, how are you going to build rapport with Aruna? How are you going to explain the diagnosis of anxiety, and how will you explain the possible benefits of psychological counseling? And I think I've spoken about her enough during the talk, so hopefully there's some good ideas that'll come through the comments, or you might even have something completely different from what I've said. So I know this is really tiny, but this is all the information, the questions, and as well as the story again. So I'll give you I guess, a minute or so, and hopefully people will have started to think about, how you're going to build rapport, how you're going to explain that diagnosis of anxiety, and how would you explain the possible benefits of counseling. So if people want to start writing things in the chat box about how they're going to build rapport with Aruna. No takers? What about any sort of, what would you do to explain the diagnosis of anxiety, or explain the possible benefits of psychological counseling? No one's keen to share or type. It's too late. Just want to get out of here. Um, so I guess if there's no takers, I'll just go through it. I guess it's really thinking about, in terms of how we're going to build the rapport with Aruna. It's maybe letting her know what kind of what you're going to do. We're going to ask a couple of questions, asking open questions, thinking about non-verbal language, having active listening, taking time to listen, being quite conversational, then being structured, listening to her story, identifying what the central issue is for her, ensuring that you talk about confidentiality and normalizing her experience. I think that's some things you might do. So I think I've started that. And please feel free to add anything that you might think. So it's, empowerment and listening is the main key things there. How are you going to explain the diagnosis of anxiety? It might be starting to acknowledge a difficult situation that she's in, explaining the anxiety can be a response to that difficult situation, and that it is a word that's commonly used to describe this pattern of symptoms, something like that. That's not necessarily right. It's just one of the answers. Something for you to think about and see if there's something else that you might do. And how would you explain the possible benefits of psychological counselling? So it's creating that sense of hope, looking at the benefits, providing that different perspective, being non-judgmental, providing that respectful, safe space. Again, it's ensuring you've discussed that confidentiality as well and explained it and checked their understanding of the health system, and depending on what role you sit in, explaining your role and other health professionals that might be involved as well. So it's really building that literacy of mental health being really important. That's really important, and that can help reduce that stigma and shame as well around that, and reduce any fear by improving that understanding. I think that was more. I think that was most of the things that I wanted to share about that. Um, so I guess it's coming back to this reflective practice, thinking about what our role is, because it is quite key. I know it's central to our clinical work generally, but even more so when we're thinking about vulnerable communities like called migrants and refugees and asylum seekers. It's not just about that person in front of us. It's also about reflecting on us as health professionals, as individuals, and our biases, beliefs, and attitudes. So just wanting to sort of close on these ponders, what approach do I already use to help me work with individuals? How can I improve my engagement with individuals by considering the influence of culture on mental health and mental illness? And what can I do differently for the people I work with? So, we might already take that person-centered approach, which means we build trust, rapport, we take an interest in that person, and we might also use a biopsychosocial framework and consider those social aspects. But it's also thinking about the broader perspective when we're thinking about a person's difficulties, identifying what their priorities might be, what their capabilities are in the context of their story, and factors that might be outside of their control. So really, I guess thinking about how we might act to support someone and empower them. So I guess the take-home message is really about being aware that we all have culture and that it influences the person in front of us, ourselves, and our engagement with others. It's more than just knowing about a culture. It is about making that person feel culturally safe through being culturally responsive so that we can support them and their mental health and well-being.
Thank you, Emalynne. Thank you for that comprehensive session tonight.